All right, good morning, everybody. Welcome to the very last Pediatric Grand Rounds for 2024. Just a reminder for everybody, we will be back on January 9th, 2025, so we hope to see you all in person or online on that day. And for those of you who are online today, just remember that I am monitoring the chat, so if you have questions or comments at any time, to go ahead and type them in the chat with everyone box, and I will read it out at the end of the presentation. And now I think I get to turn things over to Dr. Joseph Flynn, who's going to introduce our speaker for today. Thanks.
Thank you, Suzanne. It's my pleasure to introduce our Grand Round speaker, Dr. Lindsay Harshman, who comes to us from the University of Iowa. Lindsay is an established investigator in our field who's focusing on neurodevelopmental effects of chronic kidney disease. And I'm very excited to hear her talk today, where she's going to talk to us about that and talk about team science. So with that, Lindsay.
Good morning. Thank you so much for having me here. You know, Chicago tried to thwart my visit, but we overcame. So, it's okay. It is Chicago. I am so pleased to be here. I love this topic. I hope by the end of the discussion today, it'll be evident to you all that I really love what I do as a nephrologist and in science as well. And throughout the talk today, I think you'll also see very clear themes of team, because what we're going to talk about, no one person can do. Like, there's no way I could have done this on my own. And I think we'll also hopefully see clear themes of translational science, how you can take a clinical question and really just explore it and try to answer it and take this from truly the bedside actually back to the bench and back to the bedside. So hopefully this is a bit of an adventure in translational science and maybe inspires some of the people in the room to find a clinical question and just seek it out. I'm very lucky to have quite nice financial support from my lab right now. No other disclosures, no financial conflicts of interest to disclose. So outline for today. So 3 big buckets that we'll talk about. First, for those in the room or online who are not nephrologists, which is most people, we'll talk a little bit about pediatric chronic kidney disease as a lifespan issue, that our kids don't just recover and cure after transplant. This is a cycle that continues throughout their life. And then we'll jump into the idea of why on earth, why the brain? Like, why does a nephrologist care about the brain in a non-neurological disease? And then additionally, we'll talk about, again, leveraging neuroscience to optimize patient outcomes in CKD. And I really want to emphasize, I think this is truly translational to different fields. You can pick your disease of choice, find your question, and take some of the approaches we have and use it to start to answer these questions. And again, objectives to follow the outline, identifying the most common cognitive deficits in kids with CKD, explaining how cognitive and developmental brain differences could guide how we care for our patients, and then summarizing how these deficits could impact adherence to therapy, particularly within the transplant population. And I'll say too, I do transplant nephrology primarily as a clinician, and so you might often hear me refer to transplant throughout the talk, although again, there are buckets of CKD and transplant sort of separate from each other. So pediatric chronic kidney disease is a lifespan issue, as I mentioned a moment ago. And this really takes me back to kind of, again, how I got interested in this question. Why would I be interested in the brain and chronic kidney disease? And so I think anybody in the room that's taking care of our transplant recipients has met this phenotype of a patient, right? Our teenage transplant recipient, really, doing well, previously stable immune suppression, rocket it. Their kidney's doing great, they're doing great, they're active, they're involved, and then all of a sudden their immune suppression levels are undetectable and undetectable and undetectable. Why? What changed? In this case, this particular case that I'm thinking about as I discuss this and this reflection is, in particular, this patient previously, mom had actually been giving all of her medications. As an 18, 19-year-old, mom had been directly supervising. Mom had actually been measuring out some medications, some liquids in particular, because the patient struggled with pills. And then as the patient became more independent, moved out, she wasn't able to measure her TAC row appropriately in a liquid. And so what she was doing, what looked like the right dose was not the right dose. And so bringing that patient back into clinic and really going through step by step the process of what was happening we were able to impact her care positively through education. So I want to take a moment to define chronic kidney disease because, again, this sets the stage for my transplant patient I just spoke about. Chronic kidney disease is a continuous process. The transplant is not a cure. The CKD life cycle just begins again. And so you have stages 1 through 5 chronic kidney disease. Stage 1, normal function, but potentially abnormal structure. So you think about kids with a single kidney and maybe reflux into that kidney, but they have a normal kidney function. And then over time, you can see the little kidney becomes more and more empty and quite sad. And so by the time you get to stage 4 to 5 chronic kidney disease, you've got a lot of metabolic stuff happening. You've got acidosis, you may have more hypertension, proteinuria, anemia, all of these things that can certainly impact any part of the human from growth, nutrition, and cognition. And again, I want you to everybody's got coffee this morning, just take a moment, thank your kidneys, thank them, because they're working, I hope, and because of that, you have fluid balance. Your blood pressures are normal. You can eat the banana this morning, all of these things. So again, it's a process. And then we think about our kids that are in your NICU or in your PICU potentially too, right? That they're born with chronic kidney disease. So this little baby here, this photo was used with permission. We published this case report back when I was in fellowship a while back now. This little one was an 800-gram baby with twin transfusion syndrome and significant cortical necrosis and needed early life acute dialysis. That baby actually recovered some kidney function, but now has chronic kidney disease. So this kiddo is 9, 10 now and has chronic kidney disease and eventually will need a transplant. And again, we think of our kids that have abnormal kidney structure, as you can see here with the pointer, the mouse. Okay. Did I find it? But I'll suffice to say, the black is not normal on the kidney ultrasounds on the side and is showing hydronephrosis. So again, kids that have abnormal kidneys their whole life. So pause for a second. Think about that baby. Think about development. We're going to ask this baby to develop normally with abnormal kidneys. And so that makes you take pause and think about the pieces of development that are impacted with organ dysfunction, organ progressive failure. And this is normal, like otherwise control data from my mentor's lab, Peg Napolis from Iowa, which I'll talk about her in a few moments, showing what you should expect for brain development. You should see over time, again, this is cortical cerebral brain development. I'm going to separate out the cortex from the cerebellum in a little bit. That's going to be important. So we're talking about the cortex. You should see over time that you have some reduction in gray matter density, the synaptic elimination. The connections get stronger, and you really, again, you're going for high yield, high quality connections between your gray matter. And the white matter becomes more like thick, more robust. And so you see that increase. So keep that in mind, because this is what we should expect, and this is what we're asking our kids to do in the face of chronic kidney disease. So again, why the brain? Why the brain? One of the things that I often get asked is, well, is there some underlying neurological thing happening, right? What are the other neurological diagnoses that could impact pediatric chronic kidney disease and the brain and cognition? And you can see here, certainly that especially in the adult literature, most oftentimes when people think about the brain in chronic kidney disease, you think about seizures, you think about PRES, and things of the sort like CNS vasculitis with lupus. But as a pediatrician, many times if you put on your general pediatrics hat, we can think about clinical neurological diagnoses that you might see in the outpatient setting as well. ADHD, for example. ADHD has a fairly robust prevalence within the chronic kidney disease population, as you can see from this table from the chronic kidney disease in children CKID cohort, at least 12%. And I do think this is probably an underestimate, given that the CKID population is a really robust and fairly healthy population in general. But even here, 12% of this population has had seizures. So our kids, even in a well-characterized national cohort, probably have some underlying comorbidities associated with the brain as well that you can discuss in a clinical setting. But again, why might kidney disease impact the brain? So, we think about kidney disease from a variety of factors, traditional risk factors that could impact the brain: hypertension, diabetes in adults, hyperlipidemia, and that vascular disease impacting brain vessels. But you also have renal specific factors. And I'm not going to get into this too much because this is a whole different bucket of conversation, but suffice to say, I think at the essence of the brain and neurodevelopment and brain impact in chronic kidney disease, it's probably the endothelium that is really being injured, especially in adults with chronic kidney disease. And so you see a lot of risk with progressive chronic kidney disease for vascular damage, stiffness associated with, again, hypertension, endothelial dysfunction, and then direct neuronal toxicity, potentially from uremia and this accumulation of these little middle molecules over time with decreasing kidney function. And again, all of these factors likely impact the brain. And especially, again, in adult settings, you see a higher risk for strokes, but even our kids, as they go into adulthood, have higher risk for a stroke as well into their young adulthood. And all of these things, especially, this is a very adult-focused slide, but all of these things should serve to emphasize that the brain is at risk in chronic kidney disease. And really, until recently, we haven't been able to kind of figure out why is the brain at risk or what changes in the brain amongst our kids with chronic kidney disease. So again, why the brain? Why cognition in chronic kidney disease? Our pediatric chronic kidney disease patients are at risk for deficits in memory, attention, and executive functioning. Executive functioning, I like to describe it as your brain's PDSA cycle, right? You got to plan, you're going to hopefully stop and evaluate your action and then change it if needed, right? So we're all thinking of your teenagers at home right now that have none of this, but it's important. And these are developmental capacities within, again, cognitive development that over time, executive functioning, memory, and attention all become more robust with the more robust brain development. And so what we do know is that, again, having deficits in any one of these three can impact our patient care. Adherence to medical therapy requires higher level cognitive skills. Memory, again, if you can't remember to take your medications, that is a problem. Attention, well, I'm just going to snooze that reminder on my phone. I can pay attention. I'm not going to pay attention to that. I'm on, my PS5, whatever. So if your attentional capacity is denuded at all, that paying attention to reminders becomes a problem. But again, you put all of these things together and put them into, again, an executive functioning basket. If your brain's PDSA cycle is not clicking, you may potentially decide consciously or subconsciously just to put off medication taking until later. I forgot to take that. Oh yeah, I'm going to snooze that, and you walk away. And this is, I think, pick your disease or your condition of choice. This applies, and understanding where the gaps are in a patient's ability to do what we ask them. And I think it's important to realize that in pediatric patients, cognitive deficits appear even before organ failure. And this is data from the CKID study that I referenced earlier. The CKID study has been going since 2006. Seattle Children's has been a very strong participant in the cohort study. And the goal of the CKID study is to follow kids through progression of chronic kidney disease. Early on in CKID, the focus was on CKD stages 1 through 3. So again, pre-dialysis, pre-transplant. And CKID has looked at cognition. No neuroimaging really with this data at all, but it's all cognitive testing and behavioral assessments as well. And what CKID has found is that, again, development, intelligence, and executive functioning are all negatively impacted largely by chronic kidney disease. Even in preschoolers, by ages 18 to 36 months, anemia and lower GFR are associated with at-risk status for neurodevelopment, lower developmental level. Blood pressure. There's really robust data to suggest that, again, blood pressure control is important, and it's important for the brain. And that if you have more chronic high blood pressure, there is a lowering of the full-scale IQ. Proteinuria, et cetera, all of these sequelae of chronic kidney disease. One thing I do think is quite interesting is that one of the papers that came out of the CKID study said, well, yeah, again, a lot of these kids are born with chronic kidney disease. 50 to 60% of our ped CKD population are congenital anomalies of the kidney and urinary tract. And so is there something developmental? Is there something genomic that's driving this? And so even within the CKID study, looking at common genomic variants associated potentially with disease, if you have one of these common renal genomic variants, you are also at higher risk for having lower IQ. So maybe there's a developmental kidney brain component happening here. But again, the big picture is that we do see manifestation of cognitive deficits prior to failure. And school performance is impacted. And this is my small soapbox for a second. How many of you ask your patients specifically, like, what grade are you getting in math? What grade are you getting in reading? Do you get help at school? And just asking those questions can really change how you educate a patient. Because if they tell you that they're failing math, and then you're asking them to go home and carb count, or do other like complicated adjustments to their medication, how can we expect them to be able to successfully adhere to therapy if they've got deficits in school? And here again, CKID data, you can see at the bottom end of these tails, they are a third of each of these areas, reading, math, spelling, achievement. A third of our CKID patients have underachievement in multiple academic domains. And that also translates into work as well, where we see that a fairly significant number of our CKID participants are not seeking work not employed, etc. And as we start to jump into the brain data, I want to, again, take pause for a moment and think about all of these things we've talked about: attention, memory, executive functioning, school performance. And then look at this. This is an actual med list from one of our patients at Iowa who is a 21-year-old in college, failing allograft, and we were retransplanting him. But we're asking this patient to take a lot of medications and go to school amidst mild to moderate uremia, right? And so one can see then, again, if we have a significant medication burden and we transplant somebody and they've got some underlying cognitive concerns, how there is a significant risk in transplant that we can see allograft loss in the transition from pediatric to adult care when we're asking our patients to do so much. So thinking about the global context, and hopefully at this moment you're all thinking, there's a point between the brain and the kidney. There's a point to all of this. The big question is why? Are our patients just kind of being, naughty sometimes and not taking their medications? Are we not understanding how to help our patients with medication adherence, with optimizing their own individual care? And so that's where this idea of team science has come into play. This is our one of our research institutes at Iowa, where we do all of our neuroimaging work. And actually in fellowship, I became really, really enamored with this idea of trying to leverage neuroscience to understand the brain versus the being. And that really came out of gaps in the literature, that our understanding of the kidney and brain axis in chronic kidney disease was extremely limited. Prior to our recent work that we're going to really dive into here, all neuroimaging studies in pediatric chronic kidney disease were qualitative, not quantitative. What's that mean? Qualitative means we've got some series of kids that had CT scans or MRI scans for a clinical reason. Oh, we've got 10 kids, let's do a case series on this, right? And so it's a clinical review of clinically obtained scans. So there's nothing quantitative. We can't say, oh, the hippocampus is this big, or the white matter is this reduced. And despite that, though, what was seen was that there was evidence of potentially cortical atrophy and concomitant ventriculomegaly with progression of chronic kidney disease. But again, the quantitative piece was missing. The other gap, too, was that many times neuroimaging work in kids with chronic kidney disease, whether it was actually quantitative in nature, was oftentimes done in isolation from a cognitive assessment. It's expensive to do it all, and it takes a long day to do imaging and cognition for a patient. And so hence many people well, let's just get the imaging and we'll contribute that piece, but it's in absence of the full picture. And the other limiting factor to being able to actually put together a cohesive picture of the brain and chronic kidney disease, it deals with our small population. I mean, luckily, most kids are walking around relatively healthy, and we don't have a huge CKD population in the general population. And because of that, at any one center, it can be very difficult to recruit a homogeneous, like a clean sample. So most people that have published in this area just took all comers. They took lupus, they took kids with bilateral renal hypoplasia, They would take a polycystic kidney disease patient and put them all in the same study and image the brain. And that's very much an apples, oranges, grapes approach, right? It's very difficult to be able to make an informed conclusion about the impact of chronic kidney disease on the brain with these heterogeneous types. And additionally, trying to include dialysis and transplant all in the same study. It's literally a grab bag of chronic kidney disease. So this is where my adventure in team science started. As I was actually in medical school, I did a year-out research fellowship focused on neuroscience. I had psychological sciences experience before with an emphasis on judgment and decision-making. I loved it, and I wanted to do more of that in medical school. So I did a year and worked with a neuroimaging program looking actually at adults with cancer and positron emission tomography and decision-making studies. And Dr. Napolis here, my mentor, was the director of that program. And so jumped back into medical school, then stayed at Iowa for residency and decided that I love nephrology, which hopefully you all do too. And that as I jumped into that, I was like, yeah, I'm seeing these issues, these kids on our floor that they just cannot get it together. And why? Why can't they take their meds? Or what is the gap? It's surely just can't be that they're, a naughty kid. And so I met with Peg and I said, Peg, this is what I'm seeing. I think we can study this. And so my mentor, Peg, who is truly like the definition of a research rock star in many ways, Peg's experience has been in Huntington's disease. And so she's like, well, let's take what we've done in JHD and do it in CKD. She knew nothing about the kidney at all, but she was willing to take a chance on a resident, a fellow, and mentor them and literally open up her lab to me. I had endless resources at my hands that without a good mentor I would never have had, and I could never have gotten this start. So Peg worked with me to design our initial pilot study that was the pilot data for my K and then the funded K. And what we did was we went back through all of the gaps that I just told you about. And we're going to make it clean. This may be a small study, but we're going to make it clean. And so we had very strict inclusion and exclusion criteria. And I'm going to really kind of hone in on this for just a second because this sets the stage for the rest of the data I'm going to talk about. All of the kids that we've looked at thus far have had congenital anomalies of the kidney and urinary tract, CACUT, to have a clean etiology of disease. Now, there's a downside to that because it's a developmental kidney disease, right? So you have inherent risk for confounding. Now, on the contrast, if I went with all glomerular disease, like the lupus kids or minimal change disease kids, many of them have steroid exposure or CNI exposure, and that is not good for the brain either. So we just had to basically take one and roll with it, and this is what we wanted to do. The K data focused on ages 6 to 16, and my R01 data that we'll talk about goes up to age 25. And we focused largely on early stage, mild to moderate chronic kidney disease to minimize or remove the risk of dialysis or transplant on the brain. And then we also wanted to make sure we weren't unintentionally or intentionally skewing the data by including those people that have intellectual disabilities. So kids with a diagnosis of intellectual disability were not included. Kids with extreme prematurity were not included. And we made sure that kids with any CNS abnormalities like spina bifida were excluded as well. So that drops out a lot of patients, right? You think about in general, any kid that you've seen in your outpatient clinic that has chronic kidney disease, many of them have one of these diagnoses. But it set us up to have very clean data. At each study visit, so when our kids come in, just to kind of, again, walk you through the process, because I hope after this today, one of you walks out and says, I'm going to do that in whatever condition it is. So our kids come in, they have a study visit in our clinical research unit. We get blood, we get urine, we save samples. We have a metric ton of bio data that we can work through. We've done cognitive testing, including the Wechsler, the Dulles-Kaplan Executive Function System, the DCAFS, wide range achievement test, the behavioral inventory of executive functioning, developmental history, school services, so the whole gamut. So the kids doing stuff, the parents are filling out surveys for us too. And then they get an MRI. And this is the other kind of cool part, is that many times, on the clinical side, we're like, well, they're 6, they can't do an MRI without sedation. They can. And so our kids we have a research dedicated scanner. They have an hour-long scan, they get to watch a movie, and they're not sedated. And they do very, very well with that. And so we get structural scans, we get functional scans looking at blood oxygen labeled diffusion, connectivity, and then we've also gotten some metabolic scan data as well, looking at basically brain acidosis. And so again, Peg, team science, queen of research at Iowa, literally opened up her people, her empire to help this happen for this poor little, resident and fellow. The data, most of it that I'll reference here, I wanted to include the R01 data to date that we've analyzed thus far. Our total CKD sample actually is closer to 50 now, but the sample that we'll talk about today was a group of 37 kids and about approximately 2-to-1 matched controls. Controls were healthy peers from the general population around us, age and sex matched. And you can see here that the data we'll talk about, these kids were pretty similar, right? A little bit of a male skew within the group because that falls in line with the nature of our chronic kidney disease patients. Most of our CACIT patients are boys. Age matched, the only difference here with, again, EGFR is that, no surprise, our kidney disease kids have lower GFR. Relatively well matched on socioeconomic status, slightly better socioeconomic status in the controls. Relatively well matched on maternal education, again, slightly better in the controls. But really their mean blood pressures were relatively appropriate for age, sex, and height, and there was just a slight difference in prematurity as well, which is not unexpected. Our kids with CKD are a little bit more likely to be in that 30 to 37 weeks in this group. So that gives you an idea of the variables that we had to control for as we started to look at this data. The other piece that I want to really emphasize is the kids in the sample are not that sick, which is great. Their mean GFR was 71, so CKD stage 2, but you can see there is a range that we got down again to the 30 and upward greater than 90. And they were relatively well sparsed across the CKD spectrum. I'm sorry, that should be CKD4, not CKD3 twice. And then duration of CKD in this population was their age, because it's a congenital diagnosis. They are not anemic, they're not acidotic, and they really don't have a lot of proteinuria. They're well medically managed, or they're just well. And so this data, again, is the cumulative data between the K and the R awards that we've had. And what I want to show you here is you can see, again, where the little asterisks are differences, significant differences between cases and controls. The cases are in the white diamond, the controls are in the black, cases are in the black diamond, controls are in the white. We do motor skills through grooved pegboard, just to have a complete picture of cognition, what the brain is doing. Our CKD kids do have lower speeds on pegboard, so their gross motor speed is lower. They have, I would say, pretty much pan lower intelligence testing, which is fairly consistent with the CKID data showing like a normal, generally normal to leftward shift of IQ in kids with chronic kidney disease. And I would say that very much backs that up. So global IQ, performance, processing speed, and verbal IQ are all lower in the CKD patients. As you'll see, there's no domain that we look at that our CKD patients perform equally or better, okay? They have some subtle deficits in achievement. And then here, these are our two executive functioning assessments, which this is pretty profound, right? They're significantly underperforming on parental report of executive function at home through the brief. Emotional control, inhibitory control, all of these things. And then through the DCAFs, which is a very structured cognitive test, it's not a parent report, same thing. We see pan-executive dysfunction. So now that I've set you up to say that, okay, we've got cognitive deficits, we've confirmed what CKID's saying, we've in our own very homogeneous, well-described sample, what does the brain show? And this is where, again, team science starts to come into play, and mentorship, as I get to start to learn to be a mentor to others through this process, which has been an adventure. This is data that a pediatric resident, who's now a critical care, pediatric critical care doc at Vanderbilt, Matt Solomon, worked on with me throughout his residency. And this was really my first foray into mentoring, so I'm thankful that Matt survived amidst it. But what we found in this group, our initial group, this was 17 kids with chronic kidney disease, now again up to 37. In particular, the biggest shift here is the cerebellum. Why am I even looking at the cerebellum? Well, I'm looking at the cerebellum because Peg, my mentor, reminded me it's part of the brain. So you can't forget about it. You can't selectively pick and choose. So as we looked at multiple regions of interest, we when you have a brain in the scanner for these assessments, the brain data is then pushed through a processing pipeline. And those processing pipelines, very computer automated, we make sure that the brains are matched onto an anatomical template, like a standard template matched for age. And then based on that, then our computer programs can say, okay, well, yeah, the hippocampus is smaller, or the cerebellum is smaller, and you extract it into gray and white matter, or total volumes. You can kind of slice and dice any way you want, to be honest. You can get a metric ton of data. And so as we push our data and we compare it to 0, which is the standard data, the healthy control, and then our standard atlas, you can see that in general, our kids have relatively normal brain volumes, right? There's not a lot of difference except the cerebellum, and then maybe a trend towards more cerebral gray matter, which is interesting because I want to turn your memory back on, right, to one of those first slides where I told you that over time, the cerebral cortex, you should have pruning, reduction in gray matter, and so forth. So that was quite interesting here. There's not a lot of, well, there is more now, normative data to talk about what the cerebellum should do with age. And we're going to talk about that in a second because, again, the cerebellum becomes quite fascinating here. Nobody thought they were going to learn about the cerebellum today, did they? Anybody? No? So as we started then to say, okay, well, yeah, we've got these brain differences, the cerebral cortex and the cerebellar gray matter, then, well, does that impact cognition? Does kidney function impact any of this? And when we took our areas of cognition that were more kind of significant than others, we didn't want to just start slicing and dicing all the data and basically oversampling our data. When we look at the DCAFs and academic achievement, what we found was really quite interesting. You can see that on the top left here, the DCAFs, Category Fluency Index, again, an executive function measure, lower cerebellum gray matter, lower executive functioning. Arithmetic, higher arithmetic performance is happening in the kids with the lower cerebrum gray matter. So the kids that are pruning, right? And those that have the higher cerebral gray matter have lower performance on mathematic assessment. And then let's plop that all into kidney function. If you look at the kids, our CKD kids, lower kidney function, lower cerebellum gray matter. Kind of fascinating. But we could do better. And so as we moved from the K into the R01, we wanted to really explore these trends in a more concrete manner to say, okay, this is a static point in time. This is cross-sectional data. Think back to that slide. There is an effect of age on neurodevelopment. So what is the effect of age on neurodevelopment in our kids with chronic kidney disease? And so same sort of general trend here or approach. This is data that is soon to be published from our R01, where we looked at kids up to age 25. And we included age as a pretty significant feature within the sample. And analyses included this age by group interaction to say, is the difference in group happening according to age or with age? And so here, really, nothing, right? Most of the brain volumes, similar to what I showed you a couple slides ago, most of these brain volumes are pretty normal, even looking at age developmental trajectories, what we would expect the brain to do. But as we start to go into the cerebellum, dun, 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 that's where you see the difference again. And this is pretty striking, and I'm going to really, again, invoke team science here because I am not a neuroscientist. Like, I play one on TV, whatever. But this is my really good friend and colleague, Ellen Vanderplas, who is at the University of Arkansas and was previously at Iowa. Ellen is a neuroscientist and has been my partner in crime on much of this. And it's great because having somebody that is not a nephrologist forces me to think outside my box, and vice versa. I'm not a neuroscientist, so I can come to Ellen and say, Ellen, unpack this for me. Let's try to talk about what I'm seeing in clinic. And so really what we're seeing are these pretty striking age-related differences in our CKD patients that over time, so the red line represents what you would expect for the cerebellum, and our control data, it matches what you would expect. You see that the cerebellum gray matter volume is lower, and it actually drops off. It's pretty significant with age, and otherwise should be actually kind of maybe coalescing and stabilizing. You should actually see this increase in the cerebellum white matter. Our CKD patients just stagnant, right? And interestingly, the amygdala, I hadn't really seen much from the amygdala before. Now this little piece of the brain is going to come into play a little bit too, because our kids sort of paradoxically go up with age. So their amygdala volume is paradoxically increased. Okay, so the cerebellum, really? Like, really? That's exactly, as I sat in Peg's office in like 2014, I'm like, Peg, why on earth do I care about the cerebellum? And she says, well, it's the window to the soul. The cerebellum is a really complex piece of the component of the brain. Again, you're kind of a mini brain down here. And it's very much organized developmentally like your cortex. So same sort of, you see the posterior to anterior developmental progression of the brain. And same thing in the cerebellum. Those same developmental curves are happening within the cerebellum as well. The cerebellum is not just motor. That's a big takeaway point for the day. And there's been really outstanding work done looking at the cerebellum in executive dysfunction. So this syndrome up here, cerebellar cognitive affective syndrome, CCAS, is also known as Schmann's syndrome, and was well described in people, kids and adults, who had tumor resections in the specific area of the brain, the superior posterior lobe of the brain. And again, lesion studies and now even non-human primate studies have demonstrated that there is a clear executive function component to this area of the brain, in part through connectivity to the frontal cortices. So let's unpack the cerebellum further. Is this like a global gray matter reduction, or are there focal areas of gray matter reduction that are driving what we see on our slides previously? So we did the same thing as basically outlined here. We grouped the cerebellum into 5 main lobes, and interestingly, the area of the brain that I mentioned, the superior posterior lobe of the cerebellum, is where we see the big difference in our volumetric changes in kids with chronic kidney disease. So maybe there is a brain basis for the executive dysfunction we see in the clinical side. So I am super excited about this data because I think it empowers us and it empowers our families to be able to work with their children and say, this is not like something you're not just being naughty, right? There are brain bases to what we can do to help take care of our patients if we really try to take a neuroscientific and a neurodevelopmental approach, take a clinical team science approach. And so again, this work with Dr. Vanderplas, the last several slides that I've shown you, was recently accepted for publication. And one of the other features that we looked at was we said, okay, yeah, we've got these brain differences, but again, does it impact executive functioning? And it does. So these kids that have the lower cerebellum gray matter have, again, like we saw in the past, worse executive functioning. And interestingly, the amygdala, the higher the amygdala volume, which our kids had that paradoxical increase, the lower their score on monitoring, basically attention on the brief. So does the cerebellum explain everything, right? Is it just that there is this area in the cerebellum that is not developed as well, and that's it, closed book, we're done? Probably not. There's probably more. And so this is a pediatric resident, again, somebody that to me demonstrates a willingness to jump in and learn new things, that team science. If you don't have a willingness to jump in and just explore and push your boundaries, science doesn't happen. And so Dr. Ward is a peds resident who we're trying to convince to do peds nephrology, of course. And he's been looking at this data with Dr. Vanderplas and myself. And so when we take that area of the cerebellum, or the cerebellum in general, and we say, okay, again, what is the impact of the cerebellum as it connects outward to the rest of the cortex? What we find is that the connectivity from the cerebellum through a brain network called the dorsal attention network is lower in lower kidney function. So decreased output through this network to the frontal cortices. And that connectivity is substantially reduced with lower GFR. So it's starting to, the neuroscience works, right? Just like, doing your math for your sodium calculations, it works. But the big piece of it too, right, is this injury, or is this development, or is it both? Is it injury in the context of worsening chronic kidney disease and all of those endothelial things that I mentioned earlier? So one of the things that we've been doing, as I mentioned, we get a metric ton of data from these patients, including stored blood. And so we've looked at neuroinjury biomarkers in these kids, including one that's neurofilament light chain, sort of ironic because it's been really developed through like the NFL concussion literature, but it's NFL. And so this is a marker actually primarily of white matter, but also gray matter injury as well. Likely not impacted by chronic kidney disease status. And so we've looked at neuroinjury biomarkers, again, including neurofilament light chain in this population, to say, is this an injury phenomenon? Maybe injury on top of development, trying to disentangle disease from development and mechanism here. And as you can see on this slide, on the left-hand side, the blue, again, are the CKD, the red are the comparisons, are healthy controls. And with age, duration of disease, their neurofilament light chain levels in the blood go up significantly, whereas the controls are relatively flat. Same thing here, neurofilament light chain, higher NFL, lower GFR, higher NFL, lower cerebellar gray matter. So maybe there is a component of injury on disease. And that neuroinjury is not isolated. We've recently been looking at this with 2 additional biomarkers, which many of you are probably more familiar with, tau and GFAP. And as you can see here that even, again, pre-dialysis, pre-transplant, we have pan elevation of these neuroinjury biomarkers. But the million-dollar question, does transplant fix it? For those in the room that have not taken care of transplant patients or on WebEx, it's important to know, again, transplant is not an isolated issue. Some of our kids may wait a year, 2 years, 3 years, depending on situations on dialysis. And it's a lifelong need for immunosuppression. So even though we would all, I think, say, if you do transplant care, you would say, like, yes, we see improvement in our kids after transplant. Is it really getting back to where we would expect for an otherwise healthy child? Does the neuroinjury resolve? Does the brain normalize or recover the volumes that I've shown you previously are lost? This is adult data recently published, and I think it's quite fascinating. And this is 46 adult patients with CKD and end-stage kidney disease. And if you look at the group broken up here into the non-CKD controls, pre-kidney transplant, post-kidney transplant, and then a year post-transplant, healthy controls, fairly low levels of all of these biomarkers, pre-kidney transplant. This is significant, right? You've got this is in the picograms measurement as well, significant elevation in NFL, tau, GFAP, and amyloid beta. But even 3 months after transplant, goes way down, which is really quite striking. And it may actually continue to improve and or stabilize with time from transplant. But does cognition improve after transplant? I think anybody that does transplant care, myself included, would say, yeah, I think it does. But does it get back to where we would expect for an otherwise healthy child? This was data that was published by an undergrad and post-bac in my lab, and where we looked at data we had from Iowa, just that was standard of care. All of our kids we ask, suggest, recommend to get pre-transplant and post-transplant neurocognitive testing a year after transplant. And so we have all of these little spots here, and you can see the number of kids that had repeated measures data. So using a mixed models approach, what we did is we took the pre and the post data and said, again, does cognition improve? And interestingly, it may not improve as much as we think it does. The big area of weakness, so this is 0 is the norm where we would expect patients to at least recover, hopefully closer to. But when you take transplant status, pre or post, with all comers, including those that have just a single measure or those that have the repeated measures, processing speed, your ability to basically incorporate information, use it, gets worse, which is really quite interesting. And then if we look at just the kids, again, to validate what we saw, that had only that had both pre and post, again, it's processing speed that's driving the cognitive deficit post-transplant. And processing speed is an important component of executive functioning. That dorsal attention network that I mentioned a moment ago with our connectivity, that's all processing speed. So maybe what we're seeing, again, as a CKD patient really does not recover as much as we think it does post-transplant, which is important because we then have to change potentially how we take care of our patients after transplant, how we educate them, and how we support them as they grow up. The big question, though, is any of this modifiable, right? Does dialysis duration, does age at transplant, does kidney transplant etiology, do any of those factors modifiably impact cognition? Again, this is a modest size sample, but really the only thing we found that was a modifiable risk factor for not recovering neurocognition after transplant was age at transplant. And so our kids that were older at transplant actually were the ones that were driving that reduction in cognition. So the younger age at transplant kids tend to do better cognitively, which I think I would agree with clinically what we see. And that probably goes to the idea of sort of fluid versus crystallized IQ, that at some point you kind of got what you got, and you may not be able to build much more upon that. And our younger kids are much more in that fluid IQ phase where they can grow, they can learn and develop and gain back some skills. So really, this is a massive dump of kidney disease data, right? Mixed with brain, which is, it's 8:45. You're all still awake. I'm amazed right now, actually, that you've made it this far. But really, at this point, then it should make you take pause. It makes me take pause to say, what can we do? What can we do to change care for our patients? And so I think the big take-home message here is that our cognitive deficits must be accounted for in transition to care. That's that big risk, because before, we're pediatricians, we micromanage, we take care of all of these little details, but all of the adults in the room know that it's a different model of care in the adult world. It's not wrong, it's just different by nature of the patient populations and volumes they see. So where I think this all takes us is that honing in on transition of care is probably one of the most modifiable things we can do to support our patients to be successful adults, which is what we want for every patient we see. And so that may really require and push each of us in every patient group you're seeing, gen peds, endocrine, whatever, to develop stepwise integrated transition of care programs with your adult colleagues. Consider getting neurocognitive evaluations prior to transition. Again, in some general pediatric populations, this is probably not necessary at all. But in kids that have chronic diseases, it may really be worthwhile to take the time to encourage them to get in and get a formal neurocognitive evaluation. It may help them in college more than they realize, right? If they have an underlying dyslexia diagnosis that was unknown. We should also be really taking the time to do teach back. Yes, it makes your visits longer, but hopefully you're getting less calls because you know that as they leave the clinic, they understand what you're talking about. The parents understand too. And then inclusion of visual and written instructions. This is one of the biggest things, and this takes time to develop materials, but having visual instructions is increasingly important, again, based on health literacy and understanding. And so if somebody has problems with processing big pieces of information, executive function issues, having pictures to add it up, the steps that need to happen are probably also quite important. But this is a huge systems level change for what we do in many cases and takes time to develop. And so with that, lots of underlining. Sorry, guys. I don't know what happened there. That we're going to really emphasize there's opportunities here. So there's a critical need to characterize what we're doing and how we take care of our kids into the adult population. And so think about this in any field that you're in, rheumatology, endocrinology, cardiology, whatever. All of these opportunities exist in any field you go into. And so taking a clinical picture, trying to understand it and characterize it, unpack the phenotype, but then go to the mechanism. And the mechanism can be hard. Right now, that's where we're right in the midst of struggling through is really the mechanism of all of this. But opportunities are ripe if you find a team to support you, if you help support a team for the more mid-level and senior faculty that are listening, really being willing to mentor and support our trainees is a huge opportunity to enable our next generation of physician scientists to tackle these tough questions. And again, in pediatrics, multi-center collaboration is critical, breaking down walls, even if it's in your own institution, going out, attending other seminars, meeting people at other institutions. All of these pieces together, again, lift the team science boat and enable each of us to actually ask these tough questions and hopefully, again, bring answers to our patients. So with that, I'm going to take pause and answer questions that may come up. So thank you.
Thank you so much for this great talk and wonderful research and work. As a general pediatrician, I'm curious if there are opportunities for interventions that support the developmental maturation for kids who are waiting transplants, post-transplant, taking care of some kids that have been able to receive transplants. It's really exciting. And also, are there things that we can do to be more proactive in support of their developmental outcomes?
Yeah, great question. I think probably one of the very first and easiest things to do is to go back to that question of how are you doing in school? That and really pinning them down on it, because everybody, fine, I'm doing fine. Well, what grade are you getting? What help are you getting? And just asking those questions, I think really enables you then to be able to say, oh, okay, there are gaps, right? Yeah, Johnny's failing math and has failed math for years. And with those questions, although they may be moderately, I think, basic in some sense, that opens up the possibility for you to then be able to connect them with, in Iowa, it's like the area education agencies, people that can come and potentially help set up 504 plans, IEPs, and also just to be very transparent with the kid and the family and clinic and say, hey, look, you're not doing anything wrong, right? That actually it's pretty common in chronic kidney disease to have problems with learning. And because we know that, let's see how you're really doing. And that's how I phrase it a lot of times, because, many parents, we struggle with hearing that maybe our kid's having trouble in school. Oh no, his transplant's working great. He's doing great. Or, oh no, he's fine. He's going to get a transplant. But I think sometimes that layer of, our transplant patients worry so much about the medical aspect for their kids that adding one more thing becomes a shutdown moment. And just being aware of that is huge, and being able to take that and broach a conversation to say, the reason we need to help is so they can go to college, they can get a job, they can manage their medications, and trying to really just put it in a real world perspective like that, and really dive into what resources they need. I think the resources, we have so many resources in many places. Obviously some states may have different educational availabilities than others, right, based on just the world around us. But many times resources are there. We just have to dig in and find a great social worker to help too. So, yeah.
Hi. My question is about how socioeconomic status might interact with some of your findings. I noticed that there was a significant difference that you saw between the control group having higher socioeconomic status compared to the CKD group. And I was wondering and I know that there's been evidence that socioeconomic status also leads to lower brain volumes, including cerebellar volumes. Did you do any additional analyses seeing how that interacts?
Thank you for asking that question. I should have mentioned that. But yeah, maternal education and socioeconomic status were all included in the analyses, and all of the effect that we saw was the CKD. But you're right. Again, it goes back to the idea of resource and even nutritional resource, right? If you have a lower SES and you don't have access to good food, your brain may also suffer a little bit. So it's the global picture of SES in a systems-based perspective. So it's certainly taking that into account. Going back again to Gen Peds Clinic, this is where so much can happen for our patients in any field, is getting that sense of food security or insecurity, and being able to start just with the basics of our basic needs and survival. And that certainly would impact all of this too. But yes, it's all included in the models. So great question.
Great talk, and I really enjoyed your commentary about cerebellum. I can't believe it, which I thought was really interesting. Which gets to my question. There's a lot of work about cerebellum and its relationship to ADHD and autism spectrum disorders. What do you foresee in terms of reciprocal understanding between what's going on in chronic kidney disease and what you've been recognizing and what our colleagues in development have been seeing in those disorders, and what can we learn from each other?
Yeah, absolutely. That is a fantastic question. And those fields in particular, autism, ADHD, were areas that we really dug into the literature as we started looking at these cerebellar findings and seeing such similar brain differences. And again, the question then is, at what point this happen, right? Developmentally in utero, what's happening and what are the potential like drivers of brain developmental and kidney developmental differences, like these copy number variants or whatever it might be. And so for us in particular, I'm going to show you my bonus slide, everybody. It's so exciting. So we're working with mice to answer this question, because if you have something developmentally, the cerebellum and the kidney have many of the same programming genes. And if they're both impacted, right, like from a developmental perspective, then certainly it would make sense that the cerebellum could be impacted in a variety of ways. So like what we're doing right now, we have mice with isolated renal hypoplasia, basically a knockdown within the programming genes 6.2 to MEOX1. And these mice have early life chronic kidney disease, and we're imaging their brains. And I think what we're finding, sort of the word on the street from what we're seeing on our imaging, is that these mice have relatively intact brains on neuroimaging, but their cortical thicknesses and so forth and the neuronal cell counts are abnormal. So again, parts of the brain, I think, the volumes look good, but it's not normally developing. And this kidney side is probably kidney related, right? And maybe less so developmentally related. So it's that how and why and where. But it's a great question. It's the next piece of the puzzle, and why I have been forced to enter the world of animals to do this, learning lots. It's proof that, again, you can learn so many new techniques no matter where you're at in your career.
A few questions from our online folks. From Bruce Chandler, thank you for your great teaching. Do you know if kids with diabetes have similar cognitive issues?
Mm-hmm. There has been some nice imaging work within the diabetes population. They do have some similar cognitive deficits, again, executive dysfunction, but the findings in the diabetic brain are primarily white matter. Again, to my understanding and knowledge of that literature, and probably goes to the vascular nature of the chronic hyperglycemia and so forth.
Thanks. And from Emily Myers, really excellent presentation. I'm a developmental and behavioral pediatrician and work in our high-risk development follow-up program. Given your findings, is your institution considering funding developmental follow-up programs for this patient population, kind of like how we do with kids who graduate from the NICU?
Yeah, that's a great question. When I win the lottery, yes. No. But actually, we're very lucky because we have two very invested psychologists who work with us and are able to help get these kids in for evaluation and services. And actually, I have worked very closely with the DBP team in Iowa just to raise awareness to this issue, that if you see a kid come in with chronic kidney disease, it may not just be one piece. There's a global piece to a global puzzle to what they're seeing. So forming those connections, again, no matter what field you're in, go meet your friends in the other buildings, right? Go meet the DBP team, go meet the psychologists, and help them also understand about your kids with diabetes or kidney disease, and just raise that awareness. So, yeah.
Well, I think we'll call it a day. Thank you to Dr. Harshman for a great talk, and I know in nephrology we're going to be able to hear from you more, so we're really lucky, but welcome, and thank you for excellent presentation.
Thank you.